I want to do a lecture on drugs for the heart, and I really like this book, but like I told you, I hate to, this cost $68. I got it at a book show at the Cleveland Clinic when I went for an intensive review. Now this book, the good thing about this is when the Elsevier, which is a really big publishing company, they have what they call expertconsult.com, which means the book's online, and you can actually copy and paste things, so you can use it to make up lectures and stuff like that. So I'm not recommending that you buy this because the drugs change so quickly. What I want to do is I want to do one review type lecture on drugs for the heart. And so keep on the calendar, I'm asking Dr. Patch to give me one more day, and I'm hoping for Thursday, November 5th. So I want it kind of near the end before you take your second test, and it will only help you. Because I'm not going to introduce any new material, any new drugs. I'm just going to make a brief lecture based on this book on the drugs that I mentioned during the course. So we just kind of overview them again. It'll only help you for your lecture. So it's not like you're going to be getting a bunch more material by adding one more lecture. But try and keep that date open unless she says, no, I can't have that. We're going to have an extra lecture called Drugs for the Heart.
You said November 5th?
November 5th, I see a blank space at 8 in the morning. We're having Jeopardy that day too, from 1 to 3.
That's the day after the 4th off, right?
Yeah, so no reason we need to come back all with prep. Supposed to be getting ready for Project Seed. It's not before a test or anything like that. The only test that's coming up is the cardiologist test. Will really help you. So that's where I'm going to get that lecture from, is this book, because I really like it. And then as far as books that I think that you should buy, I strongly recommend that you get this. It has a CD that comes with it, which I'm going to open up for you in a minute. This is called Auscultation Stills, Breath and Heart Sounds. It costs about $25. It has the most gorgeous, all the pictures are color in it, and it just, it's really easy to read. Love this. This is Wolters, Kluwer, Lippincott, Williams, and Wilkins, that big company that merged. This is the best book I've read. It's got the photocardiograms, the drawings, and all that. It's the best book I found on auscultation skills, breath, and heart sounds. It tells you exactly how they're made. So I use this as a reference when I write slides about heart sounds, and when I use that. So, but the CD is really helpful. So I'll play that the stuff from the CD that comes with it. So yeah. Yeah, you guys can pass this around, and I'm going to need the index when I go to do the slides, because it tells me which number on the recording to find it. I highly recommend that. Now this one, I'm going to play some slides from it. He's got some really good patient recordings and some he sings recordings. And I met this guy, Michael Chisner, this cardiologist. He's a very energetic, entertaining kind of guy, and it's one of those ridiculously simple books that they're pretty easy to understand. So this wasn't too expensive. I think it was maybe $25 or $30, but it's published by MedMaster, which they publish review books and stuff. So as far as a cardiology supplement, I recommend this one. It's not the ultimate authority. I mean, there's more scientific kind of stuff, but it's very good, very clinically oriented. So that's it that I recommend for cardiology books. Besides like Hearst, the Heart, and those classics and stuff like that, cost a fortune, and you should just have them online. Now, another interesting thing, I didn't bring it in today, but the same company, Elsevier, that has Expert Consult, the EKG book we're going to use, which is Goldberger, Clinical Electrocardiography, is available online. So I was really excited when I saw that. So I noticed not everybody bought an EKG book last year. EKG books don't go out of style. It doesn't matter. I used one from 20 years ago, they're fine. So when we go to do the EKG course in January, I want at least maybe you and your roommate get one book for the two of you, because the EKG books maybe, it might have been like $45, not that cheap, even though it's paperback. Just get one copy, and then you have electronic copies that you can look at. You can't share it with too many people because you have to have an email and a password. So unless you make up an email that you don't care that other people can get in there and use it, you do that, don't even tell me about it because it's probably illegal. But I want to see more copies of the EKG book come.
Which EKG book is it again?
Well, it's not till January. That's why I didn't bring it to you. If you want to get it early, you can. But the point is, it's the same company, and it's online, and you can copy and paste things out of there to make your own notes of the book, look at the pictures, and it's very, very helpful. It's called, and I met the author and went to one of his seminars he's a real intellectual guy, and he writes in a way that you can understand. His writing is beautiful. His name is Harry Goldberger, Clinical Electrocardiography. Well, I like it because it's clinical. Okay, so you know about the schedule, you know about my favorite books, and I'm gonna talk to you just for a moment before we do this lecture, which is only about 25 slides. Maybe we'll get done early. I wanted to tell you that we're gonna talk about 4 murmurs today that are just the same as the 4 murmurs that we just talked about. And it's so easy to tell the difference between them. And this is also pants material. It's on the NCCPA blueprint. Everyone knows what I'm talking about, the NCCPA blueprint. All these lectures in cardiology, they're based on that. The topics that we cover are all on the NCCPA blueprint, and maybe a little bit more. So we're going to talk about the tricuspid and the pulmonic valves, the valves on the right side of the heart. So of course you've got blocked or leaky, so you've got tricuspid stenosis, tricuspid insufficiency or regurgitation, and then you got pulmonic stenosis and pulmonic regurgitation. Now those correlate exactly with aortic stenosis, aortic regurgitation, which would correlate to which valve? The aortic would have the same sounds as the pulmonic, and then the tricuspid stenosis and regurgitation would have the same sounds as what valve? So what do you think is the one main difference in the sounds? They're similar, but the difference is what? That's the thing that's the same as whether it's systolic or diastolic. So that's why these are classic. I'm only really going to have you memorize 4 murmurs that are classic kind of sounds. So you're going to have to remember which one goes to which and whether it's systolic or diastolic. But the thing that's different is the location, okay? Because the aortic valve you're going to hear on which side? The right side, and the pulmonic sound you're going to hear best on the left side. So it's just that it's louder. And then the tricuspid you're going to hear best where? This left sternal border. And then the mitral you're going to hear best where? At the apex. Mitral sounds usually best at the apex in the midclavicular line, or the, yeah. Okay, and the other big difference between right-sided and left-sided murmurs is right-sided murmurs vary with respiration. Important point. So when you're listening, do you think they get louder or do they get softer when you breathe in? What would be your guess?
Louder.
Louder. Very good. Can you tell me why?
Because of negative pressure
Yeah, because of negative pressure where?
in the venous system when we breathe in.
Yes, negative pressure in the venous system causes increased or decreased venous return? Increased venous return, correct. And you create negative pressure in your chest by doing what action? Dropping your diaphragm, right. When you breathe in, your diaphragm goes down and you have more airspace. So now you have negative intrathoracic pressure, and you have decreased venous or even collapsed vessels during inspiration. And then the blood rushes in to fill that space. The venous blood comes from below and above. And then now you have more blood on which side of the heart? For a moment, just for the moment while you're breathing in, you have increased return to which side of your heart? Right side of your heart. And that translates to a change in the way the murmur sounds just while you're inspiring. So that's how you can differentiate, is this a tricuspid regurg or is this mitral regurgitation? It depends on where it's loudest and what it does when you breathe in and the clinical history. Right-sided murmurs are not as common as left-sided murmurs. Okay? Very common murmur is aortic stenosis. Mitral regurgitation is common. But tricuspid, when we do the lecture, you'll see there's specific conditions that can lead to problems in the tricuspid valve and the pulmonic valve. So less common than left-sided murmurs. So your history should go along with when you hear the sound. So when you get a case study on your test and it tells you that the person is 65 years old and they've had hypertension for 30 years, you're going to think of a problem with maybe the aortic or the mitral valve, right? On the left side of the heart. That might be giving the murmur. And then if I tell you that the murmur is holosystolic and is heard at the apex, you're gonna think not aortic valve, you're gonna think this is a mitral valve problem. So maybe the person has just some left ventricular hypertrophy, and maybe the valve is starting to leak, the heart's starting to enlarge. That could be what's happening. So it has to make sense with the history. You wouldn't think they had, why should they have tricuspid regurgitation? Just because they have hypertension. The right side of the heart doesn't do that as much unless they have, what if I told you they had COPD? If they had chronic obstructive pulmonary disease, and they had signs of right ventricular hypertrophy on their electrocardiogram. Even if you can't read an EKG, if I told you that, if you read that in a report, then you would know you were looking for a right-sided lesion. And you might pick that they had that, or that they'd had a pacemaker, and something that might make the tricuspid valve incompetent. So you've got to start putting together these patient stories. They got to make sense, right or left. Yeah.
If the person has pulmonary hypertension, will that respiratory variability go away? Of the right side?
Yeah, pulmonary hypertension, no. Will the respiratory variability go away? No. No.
Didn't we learn that today? Cathode? Is that what you said?
Still hear murmurs.
No, the variability that comes, doesn't that?
Well, you get an increase in the P2 component of the second heart sound with pulmonary hypertension. So that's still going to make the second heart sound louder than the first heart sound in the base of the heart. And when we do heart sounds lecture, we'll differentiate how to tell what S1 is, how to tell what S2 is, which one is supposed to be split, and things that make third and fourth heart sounds. But today we're just going to concentrate on the four lesions I just talked about. We're going to move to the right side of the heart, but let's remind ourselves what they sound like from the left side of the heart. And this is my stethoscope. Anybody want to look at it, you can. This is a real expensive one. I got a little discount for working for NCH, doing consults over there when I had privileges at the hospital. From the medical supply store. But this one's like $300. It doesn't have a bell and a diaphragm. It just has a diaphragm.
Is that the cardiac master one?
Yeah. So when you just press lightly, it's a bell, and then when you press a little harder, it becomes a diaphragm. And I like it because it's sort of teardrop shaped, and it fits really nice in here for listening for carotid bruits. I just stick it on the neck like that. Plus it's just, I don't have to be fussing around with my hands flipping it like that. So it's all one-handed kind of stuff. It just fits on your fingers like that. So they make other nice ones too, but I really like these Litton stethoscopes because the tubing is together. The Hewlett-Packard ones was the first ones that I had, and they were double tubing. And sometimes the tubing rubs and makes little noise, and you have to wait till it quiets down, quits moving. But this one's worked good for me for my ear angle and stuff like that. It's really comfortable. So you can try my stethoscope when we do the lab and see if it makes any big difference when you're listening to your neighbor, that kind of thing. So it's not, you don't absolutely have to get one, and I know you're not all going to be in cardiology, but make my life a lot easier. Okay. So this would be, let's see if it works.
Right.
Rawr. Did you hear that? Can you tell how it's diamond shaped? It starts out softer. It's between S1 and S2. These are the kind of pictures we're going to practice drawing.
That also called crescendo.
Yeah, crescendo, decrescendo, diamond shaped, or ejection murmur. It's louder in the center. It's harsh. So a harsh systolic ejection murmur at the what intercostal space? Second, right or left? Right intercostal space would be aortic stenosis. More commonly degenerative or congenital? More often degenerative aortic stenosis. Tons of that. Some people are born with how many cusp aortic valve? Bicuspid, but a lot of it's degenerative because we're just living longer and we're having high blood pressure, and all those heartbeats eventually starts to calcify the valve. And where does it radiate? Carotids. And which side of the neck might it be louder? The right. But sometimes it's equal, and sometimes it's just the right side. Now here's the honking kind when it sounds like a honking goose to me. Oh, he's singing. He's a good singer. He really is. Okay, whoever laughs has to sing it and tell me see if they can do it better. It's hard to do. And I know that I got no emails, so I know you're all studying for the ENT test and nobody watched the Widowmaker. So I forgive you, but I'm hoping to get a few emails after the weekend. Okay, so he's saying it so you could hear the S2 is tough. He says tough instead of double. All right, let's go to another one. Okay, pulmonic stenosis, also a systolic ejection murmur.
Love. Go. Love. Go. Love. Go.
He's great.
Love.
I wish I had that.
Go.
Okay, now, you see where he's showing where you hear it? He's showing the heart. No murmur, no child's heartbeat would ever be that slow or they'd be dying. Kids have rapid heartbeats. But he's trying to show you how you would hear all that. Do you see where he shows it? Okay. And then I have listen to a couple more, and then I'm going to show you a really wonderful online program I found.
Is this program that you're doing from the book that you talked about?
Yeah, this is a CD that comes with the book. So you won't be able to, okay, here's patient recording, blowing holosystolic fixed murmur. Okay, best heard at the apex. So they're showing you there at the apex. And actually, it's best heard in the left lateral decubitus. And what do you think, the aortic stenosis, what do you think is the best position for listening to that?
Sitting up.
Sitting up, not leaning forward, but just sitting up. I hear it because you can just be up here better. When you lay him down, where does the heart go? Like further away. So actually hear it better with them sitting up. And then for the aortic insufficiency is the one you want leaning forward because it's so soft that and you want to get all the air out of the chest. But the aortic stenosis, you don't have any problem just hearing it with them sitting up. So this is, instead of crescendo, decrescendo, holosystolic means holo throughout systole. So it's the same. Sometimes it doesn't sound quite so like galloping, horsey kind of noise, but you can. It's been amplified many times. It would never sound that loud to your ears, but and sometimes it just sounds like ooh, 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 or different pitches. But the point is, it's pretty much the same. It's not so obviously so harsh and roaring kind as the aortic stenosis murmur, and it's not. You're not going to hear this well. You're going to hear this loud at the apex and up here, and then you move around. And you say, oh, I don't hear it at the base of the heart. So keep this straight. This is the base at the top. And this is the apex here. It's the opposite of the lungs. What do you call the lungs up here? What's this part of the lungs? Apex. And what's this part of the lungs? And what's this part of the heart? And what's this part of the heart? So it's the opposite. So it's inverted cone. Lungs go this, like that, sort of, and the heart goes like that, the opposite. Good on that? You see the drawing, how if you draw S1 and then you draw S2, and then this is diastole between S2 and S1, and it's silent between there. So it's systolic. So if you were to draw, that's how you do it. We'll do some drawings when we do our heart sound lab stations. Okay. And let's see what this, this may be him singing. But well, look what he's trying to show you.
Go. Go. Go.
here's expiration.
Dup. 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 Dup.
So look, where is he showing you? Where do you put the stethoscope? Where? Yeah. Is that the apex? Yeah, it's the tricuspid area, not the apex. So the difference was, what I told you when I walked in, it's the location, it's the variation with respiration, and it's the patient history. That's how we tell, but it kind of sounds the same as. Aha, good. See, we have a bump, click, bump. Now, see the drawing of it? See S1? A click, a sharp high-pitched sound, not a murmur, a hard sound in between S1 and S2 from the redundant, prolapsing, or doming piece of valve pushing up into the atrium. I guess some people have multiple clicks. I really don't hear that too much. Sometimes after the click, so you would have a late systolic murmur if you have a murmur with mitral valve prolapse. What's the murmur caused by? Mitral regurgitation. And why isn't it holosystolic? Didn't we say mitral regurg murmur is holosystolic? And if this is mitral regurgitation?
It doesn't regurg until the valve is incompetent.
Yeah. It doesn't regurgitation until that prolapses up and it lets some, so that makes it incompetent. When it prolapses up, some blood is able to get past the valve. So that's how you would tell if it was that. And you can hear it in pretty much the same area, but the interesting thing about mitral valve prolapse is when you change positions like squatting or standing, it might change the click where it occurs. So let's see if we can tell. Bump-a-dum, 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 bump-a-dum. You hear three sounds. You don't hear bump, 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 bump. You hear bump-a-dum, bump-a-dum. Anyone hear that? Everyone got that? I know it's subtle, but there was three sounds there, not just two. And the murmur was hard to hear. It was really soft, but there was a little bit of murmur there. I think he's singing it. Oh, he has some pretty energy. He's far better than me. I just swallowed bump, just bump, bump, big bump, 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 bump. Seriously. So you can have different kinds of sound for that, a little bit of regurg. Okay, got the idea? So the only thing, I don't think he has aortic insufficiency on here, so I want you to hear that. Because that is a really cool one once you hear it. A VSD, this is a real one. Remember we talked about that on the first day? Oh, I think we just had a singing. We got a singing Dr. Chisner. The important thing is it's accompanied by a palpable systolic thrill, and you have an echo report of a hole in the heart, and you have a younger person that might have this. So the history has to go along with it. You're not going to get a thrill with mitral regurgitation, but a VSD causes enough turbulence going across that hole that it'll cause a thrill. You don't get as much turbulence. Okay, so let me just show you the other. Here's the CD that goes with that book. And I want you to hear, hope they have a good one on aortic insufficiency. I think these are computer generated though, not patient recordings.
One, normal S1
Okay.
and S2 at base of heart.
Tell me the
Two basic heart sounds, S1 and S2, are produced by a normally functioning heart.
List of where-
They're generated by closure of the heart's valves and vibrations associated with closure and blood flow
They
changes.
have like a list of,
S1 marks the beginning of
Right.
ventricular
So
systole,
they got
and
Austin
S2
Flint
marks
over
the
here.
end. Listen to normal S1 and S2 heart sounds.
okay, so you wanna go to?
2,
uh,
8, 9, 20, 25, 20, 27, 28, 29, 30, 32. Aortic valvular stenosis murmur. Aortic valvular stenosis, or both. An aortic valvular stenosis murmur
You do a lot of
produces
teaching with it. Sounds just like that. That's a good one, okay.
33. Subvalvular aortic stenosis murmur.
Okay, Carol.
An obstruction to left ventricular outflow below the aortic valve, or subvalvular obstruction, produces a crescendo-decrescendo murmur. 34. 35. Holosystolic mitral regurgitation murmur. A mitral regurgitation.
You really can't hear the first, it obscures the heart sounds a lot of times.
36. 37. Mitral valve prolapse murmur with click.
Very hard to hear.
38.
Very hard.
Early diastolic aortic regurgitation murmur. The turbulent blood flow associated with the backward flow of blood across an incompetent
That's very, very
39.
loud. It's almost
Austin
never,
Flint murmur.
it's almost never that loud. It's almost like, like a blowing out sound. That was a little, and it's always high pitched like that. And it's always really hard to hear, and you've got to get all the air out of their chest like I showed you, and you've got to get the heart all the way forward. No breathing, quiet room, and super concentrate where you know where the first and the second heart sound is, and listen after S2. This I'm gonna have a hard time hearing where S2 is in that. See if they tell you Austin Flint. Does anybody remember when we talked about what an Austin Flint murmur is? Remember that description? Too new to be able to talk about it? Okay. Remember, and I just told you about this because it's a complex thing to remember, but it's still an aortic insufficiency murmur, but it's a jet that's hitting the mitral valve. Okay, because they're both on the left side. So it's making a pseudo mitral stenosis murmur, and the murmur of mitral stenosis, which is just something you gotta memorize, is a diastolic rumble. So it sounds like mitral stenosis, so we'll see if it does on here. Austin Flint's number 39.
Severe aortic regurgitation may be associated with a mid-diastolic and pre-systolic rumbling murmur. This murmur is caused by the aortic regurgitant jet moving the anterior mitral valve leaflet toward a closing position, resulting in a relative mitral stenosis. It's called an Austin Flint murmur, and it's usually heard best with a stethoscope spell near the apex of the heart over the mitral area. It has a soft intensity and a low pitch, and sounds like this.
Okay, now
40.
I know that sounds subtle, but if you listen carefully, you would have heard bump, ba-da, rump. Would help if I could roll my R's, but it's bump, ba-da, rump. So you had an opening snap. There was a third thing going on there. You heard two sounds, the lub dub. I heard a third sound, that was the opening snap, and then after the opening snap, in diastole, you heard a rumble that got louder right before S1. The period, so this heart was never quiet. You had first heart sound, second heart sound, a third heart sound, which was an opening snap, and then a rumble. It's after S2, it's quiet. You hear lub dub, quiet, lub dub, quiet from the heart. So practice listening to each other's hearts, and you'll hear how quiet diastole is. So it's not quiet diastole. It's easier on a real patient than a recording because you can feel their pulse, and if you're not sure what S1 is, you just feel the carotid upstroke. That's S1 when you feel the carotid upstroke. Okay? And then the stuff that comes after that will be diastole before you have your next heart. And we'll just do mitral stenosis and we'll get away from this. This is in sinus rhythm, much easier to hear than when they're irregular rhythm.
43. Mitral stenosis murmur, normal sinus rhythm.
Who could hear?
44.
Who could hear 3 sounds and then a murmur? Anybody able to discern that there were 3? Anybody hear the 3 sounds? Or you couldn't discern it? Who couldn't discern it? You just heard a bunch of noise. Okay, we'll keep practicing. It really takes a lot of skill, and it's hard because the heartbeats are fast. Now, I want you guys to write down this website, because this I believe you can slow it down. Because I can't get rid of that till I exit there. This is a gorgeous, gorgeous site.
Is it better than the one we have at the school library?
I don't know. I like this has got a quiz and everything we can. Here's what I was trying to. This is what I was telling you about physiological split of the second heart sound, and you can actually see the pulmonic valve being delayed, and I think you can slow it down. So this is what we're going to practice on each other, making the S2 split. Because remember, when you're breathing in, you're dropping your diaphragm, you're decreasing your venous pressure, and you're having increased venous return. And if you're delaying the closure of the pulmonic valve. So you're having a physiologic split of the second heart sound is different from a fixed split. What condition, Pam's question, results in a fixed split of the second heart sound? Which condition? Yes, atrial septal defect. I heard it. Okay. And that was because, how did that all happen?
There's 2 ways the right atrium can get blood flow out of it.
Yeah, 2 ways the right atrium gives blood flow, from the return, the normal return, plus from the defect from it goes left over to right because the pressure is higher. And the reason it's fixed with aortic atrial septal defect is because the hole is fixed. The hole doesn't come and go, but breathing comes and goes, right? You take a deep breath, you increase the flow, but if you have an ASD, it stays increased, always. So every heartbeat, you're going to have a fixed split. That's why it's fixed. So I think it's really beautiful to watch that. So the murmurs and things, you can see the blood flow. Then they talk about some of those pulses, Quincke's pulse, some called Day-Musset or just Musset, Sine-Corrigan's pulses and those sort of things. That long list I gave you was not to intimidate you or make you have to memorize them. I just thought it's kind of fun if you see all the different ways that aortic insufficiency causes bounding pulses, that you can observe it in the body, and the wide pulse pressure. So that's all that was for. So maybe I might ask you about the fact of the bounding pulses, but not ask you to remember the specific name of one. That's not important. But then hopefully you'll go and look at that site and look at the Quincke's pulse. Maybe we can do it now. Now, the reason why this has two murmurs, so they're showing you the bounding growth you can see in the neck. It has a little systolic murmur, and it has that high-pitched flowing diastolic murmur, a little harsher than what it sounds like to me most of the time in the recording. Is because when you get so much volume in the ventricle from that regurgitating, from severe aortic insufficiency, when that gets pushed out, that causes some turbulence across the aortic valve, so you're getting a little bit of systolic murmur and diastolic murmur. And that's a little harder on you when you've got more than one murmur to try to be describing them. So the best way to sort out murmurs, if they have more than one, is to listen to a particular spot and describe in your note what you heard in that particular spot. Say they have a murmur at the base of their heart, and then they have another murmur at the apex. So that's how that all starts. But that's where that. But that's pretty good recording. And they give you all that other good information. Look at the pulses on her. This is a real person that has this. This one is extremely difficult to hear because of a heart rate at 110. It makes it very difficult for you to discern what's going on. This is more like what I was saying to you. Do you hear that flowing diastolic murmur? I think you all would know what that was. When you put your stethoscope on a patient and you hear this, they might have a thrill, and it's a transmits up to their neck, and they're older. You'll recognize this right away. Hear the difference between the mitral regurg and the aortic stenosis? This is much more the same sound. It's not a diamond shape. And you can just, did you write down this website? You can just go back and practice this and take a little quiz and see if you get any of the murmurs right. It's fun.
What is the website?
What is the left side? Oh, it's blaufus.org. BLAUFUSS. Just blaufus.org and you'll find the tutorials. Okay. And just wanted to show you. See, there's the quiz. And then we can use it for EKG too. It's kind of fun. I use a 6-second EKG simulator too. So that'll be next semester. Aortic insufficiency.
Yeah.
Yeah, it's turning red and then normal. It's his pulse you can see in the pink toe. What's wrong with his toenails? Yeah, onychomycosis, yeah. Isn't that so cool? So you can see how everything bobs and moves. If it's severe aortic, the neck arteries huge, you see it in their throat, you see it, their head bobs. There's all those different signs. Oh, that was pretty cool. You need a break before we do the lecture? Okay, you want to just get through the 25 slides?
Yeah.
Okay. It's really not bad because, hey, remember what I said at the beginning? Same stuff I already taught you. I'm just going to tell you when you get these other. You can passing this down if you want to consider buying yourself a copy.
I put the ISBN for that.
Did you? I
Well,
mean,
for the
I haven't looked-
auscultation book, I just put the ISBN on our Facebook page. So.
Okay, because I've looked at tons of books, and I'm telling you, that just has the best pictures and the best explanation. Right?
What do you think of Diamond's book?
Dr. Diamond, I only know about his review book for the pants. You talk about that one?
Yeah, I think that's.
I have it, and yeah, I like it. He's a great guy. Can't get rid of that, but that's all right. Okay. Did I drop this clicker?
No, you left it over here on your book,
Oh.
for your books.
Oh, thank you. I'm not quite seen that yet. Okay, so just four lesions. We'll talk a little bit about antibiotics here. Okay, NCCPA blueprint, tricuspid stenosis and insufficiency, and pulmonic stenosis and insufficiency. And we'll talk about endocarditis, that's also on there under other forms of heart disease. So, if you study all the objectives for the, from the NCCPA for the PANT, you should do fine. So if you know a little bit about every single topic, you won't miss anything. So when you see those echo reports and it says they have trace regurgitation in these valves, it doesn't mean that all their valves of their heart are leaking. It's a normal or physiologic leakage. Pulmonic stenosis, who do we say that happens in? Remember the very first lecture? Yeah, babies are born with pulmonic stenosis. It's not something that happens as a degenerative disease such as what's its correlate. Aortic stenosis. Now aortic stenosis takes a beating from all that blood being injected from the powerful left ventricle. The right ventricle, again, has its only job is for the pulmonary artery, and the pulmonic valve's only job is to get the blood a couple of inches here, right? Over to the lungs. It doesn't have that work to do, so it doesn't degenerate like the aortic valve does. So it's when only, how many leaflets does it have?
Two.
The pulmonic valve?
Right.
There's only one artery that has, or one valve that has two leaflets. That's the bicuspid valve, or what's its other name? The mitral valve, yeah. So all the rest have three, because remember, it's if they're fused, and then you say, you've got pulmonic stenosis if you have a fused leaflet and it looks like there's only one leaflet or two leaflets instead of three. So you have fusion of the commissures. And they can have repeat procedures. If they have pulmonic stenosis, baby can keep having that done for child. So just like aortic stenosis, if they have that, they get fatigue. And there's the main difference between that and the aortic stenosis. The murmur is the left upper sternal border rather than the aortic stenosis is on the, which border? Where?
Right.
The right, which intercostal space? Second. Okay. And you may have other things to help you. The echocardiogram or the electrocardiogram may show you right ventricular hypertrophy. And you don't have to put a balloon in there unless if it's mild, you just keep watching the child. That'd be the most common situation you're going to see pulmonic stenosis. And like the mitral commissurotomy, they used to do a commissurotomy, but they had opened the chest rather than do it from the side and stick their fingers in the chest like they did originally with mitral commissurotomy. So usually they replace it. Do you remember the Ross procedure? I told you about that. The Ross procedure, I think it was on the other side, where you take the pulmonic valve and you put it in the place of the aortic valve in children because it will still grow, and it's like getting a homograft, which means human from the same person, not a heterograft or a xenograft. A xenograft is when it's another species, animal tissue. So. But you wouldn't take your aortic valve and put it in your pulmonic valve place, because then you'd have a bigger problem. You'd put a big one in there. So they'll replace this one, because this one won't take the wear and tear as much as the aortic valve. Or the preferred treatment is the valvuloplasty with the balloon. Okay. And so that's the same slides as the as the other one. So if the gradient, and this is what some of you weren't understanding, the difference between the valve on either side of the valve, if the pressure buildup is greater than 50 millimeters of mercury for a pulmonic stenosis, that would be considered severe. Whereas aortic, it's more like 80 millimeters is very severe, but 50 is significant for aortic valve too, that they would consider doing something. So the gradient was the difference in pressures pre and post the valve, because once the valve is open, there's really not much of it. There's no gradient because the blood has to be able to go through there. Okay, so it's a very good result with that. So parents shouldn't panic. It's not cyanotic heart disease if they have pulmonic stenosis. They should come back every year. So we wouldn't expect it to shorten their life. Do you remember the 4 things that included pulmonic stenosis and made tetralogy below? Do you remember the other 3 things? You're going to need to know this for your first test, and then you're going to need to know for your hand. The overriding aorta, pulmonic stenosis.
BSD.
It's a VSD actually. That's a VSD, no, it's a VSD, sorry. We said that overriding aorta, right ventricular hypertrophy. Right ventricular hypertrophy, VSD, overriding aorta, and pulmonic stenosis are the 4 components of tetralogy pulmonale. And it's cyanotic heart disease, and it should be operated on soon, because it has a lot of mortality if you wait. Okay, so that's all we're going to say about pulmonic stenosis. Okay, so tricuspid insufficiency or regurgitation. Here's a picture of it. So you have some regurgitative jet going back into the right atrium when the valve closes, which is supposed to, that deoxygenated blood is supposed to go out the pulmonic artery, right? Go pick up oxygen, but missing some. The causes of it, it can be from IV drug abuse, because if someone is sticking dirty needles into their arm, where's the first place it goes? The bacteria from that, the first place. Yeah, and that's the first valve it's going to hit, isn't it? So repeatedly doing that, exposing yourself to bacteria like that, bacteremia, that's the first place it's going to go through. That's the lower flow, correct? On the right side of the heart, aren't the pressures lower than on the left side of the heart? So that's where possibly bacteria is going to hook on. So it's most common site vegetation is growing. Another way is any kind of trauma to the tricuspid valve. And there's trauma when they put in pacemakers. The lead goes from the subclavian vein, and it goes to the right side of the heart. Because you can't put a pacemaker wire or lead into the left side of the heart because it will be extremely irritating and cause ventricular arrhythmia, and it will be ejected by 120 millimeters mercury pressure. So it would flail out of there. It has to be under the low pressure system, and it has to be attached to the heart. So the place they attach pacemaker wire is to the interventricular septum of the right ventricle. So how do you get there? You actually push it through the tricuspid valve. So over time, if you have enough hardware in there, then it could cause that valve to be competent, because they don't always take the wires out. Sometimes the pacemaker wire breaks, or they decide to upgrade the pacemaker and they have to put in, or the lead is no longer interfacing with the muscle on the wall, it's not giving a signal, so they put another one in there. So they're very, very fine, not even like angel hair pasta, they're really fine wires. I forgot to bring them today, but we'll talk about pacemakers again, and I'll bring my pacemakers in class. And so the tricuspid valve can become incompetent. If they have a heart transplant, they have to take little bites of the inside of the heart, which you don't have sensation inside the heart, and they'll put the catheter through, they do a right heart catheterization, and it goes through the tricuspid valve, and they take a little bite of the septum. Well, sometimes they take a little bite off the papillary muscles or the tricuspid valve itself inadvertently. These things are all very crowded and close together, and that can make the valve incompetent. So infection, trauma, or lead placement are three of the most common ways of making the tricuspid valve regurgitant. It's not like the left ventricle. What's the corollary to tricuspid valve regurgitation? The corollary to it that makes the same number? The mitral valve regurgitation. Now, mitral valve, we don't do biopsies on the left side of the heart. That's our pumping chamber, our main pumping chamber. We don't want to take any bites of tissue out of there, no biopsies ever. So the mitral valve, it gets incompetent for completely different reasons. It gets incompetent from stretching of the heart and stretching of the annulus of the mitral valve, so the leaflets won't coact anymore, such as hypertrophy, or that's the main reason. The dilation or hypertrophy of the left ventricle can cause that. And just wear and tear too, degenerative type reasons. So if you have pulmonary hypertension, here's a way, and you have to think of the heart as a whole, not as just like right-sided problems and left-sided problems. I do that to oversimplify it. But you could have a left-sided problem that causes a right-sided problem. That's what I meant in the second, number 2. Let's say you have mitral stenosis. So what happens with your left atrium if you have mitral stenosis? Remember the x-rays we looked at? It enlarges. And if the right atrium enlarges because there's blood left in there, they can't get through the mitral valve. Now the pressure is higher in the left atrium. And where does that transmit to? The pulmonary veins. Okay. And where does that transmit to? So where do those pulmonary veins, the capillaries, and then where to? Alveoli, and then eventually to the right side of the heart. So the venous system is going to be increased, higher pressure in the whole venous system of the body, and now you're going to have higher pressure even in the vena cava, even when you put that blood in the back in the where? Returning from the body. The right atrium. Now the pressure is higher all the way around. The entire body has elevated venous pressure. So it's higher in the right atrium, and it's going to cause possibly, what's the next chamber after the right atrium? And it goes down to the right ventricle. And if the pressure is high in the right ventricle because we got all this venous return, what's the right ventricle? What's it going to do? The right ventricle from this pressure. It dilates usually from that situation. But then the right ventricle is not as muscular, it doesn't hypertrophy as much as the left ventricle hypertrophies more. But it could hypertrophy or dilate. And then what might happen to the tricuspid valve? Regurg. So we got mitral stenosis on the left side, and that could result in tricuspid regurg on the right side. You see how all the way around, the first thing I told you about the heart, you have to have normal intracardiac pressure for it to work properly. You don't want, we're gonna get leaky valves. If we have blocked valves, it could cause leaky valves. Blocked valves could cause hypertrophy or dilatation. It's gonna just increase intracardiac pressure and could cause heart failure. So, we got some ideas how you might get tricuspid regurg then? Different from how you might get mitral regurg. Do we remember the sound, how the sound of tricuspid regurg would be different from mitral regurg? The same yet different. It's the same in the intensity and the quality and the timing. But the difference is location, and the other factor is respiratory variation. That's a really good question. Two things that are correct that'll change it. Okay. So echo confirms. These are all things that show you if it's so bad that you're getting a backup of pressure because all that extra blood going in from the right ventricle to the right atrium, that again transmits to the venous system, right? We have our vena cava coming in. Sorry, this is the right side. The vena cava, higher pressure, because my right atrium now has too much pressure in it, and so I'm gonna manifest that by my jugular veins. I'm gonna have jugular venous distension because that cannot empty as quickly into the right atrium as well. So it's gonna bulge out from higher pressure in those vessels. And my legs are gonna swell because I'm gonna have higher pressure all the way to the veins in my legs. And clear fluid is gonna exude out of my veins into my tissue. When you push on my leg, you're gonna see pitting edema. Grade 1 through 4, edema in the legs. Signs of heart failure. My lungs, my capillaries are gonna exude fluid into my lungs, and on my x-ray, you're gonna see opacifications from fluid. You're gonna see curly V lines and fluid in between the fissures of the lung. And I'm going to be short of breath because I can't get as much oxygen in my alveoli because there's water in there instead of air. I'm going to be tired. I'm not going to be able to walk as far. I'm going to have exercise intolerance. I'm going to have conversational dyspnea. I'm not going to be able to talk to you because I'm not going to be able to finish my sentence. It's hard to breathe, and I'm going to be breathing faster. I feel like I can't get air. I feel like I'm drowning. And I'm going to cough someday, and it's going to be pinkish. I'm going to see blood. I'm going to feel exhausted. I'm going to be afraid to sleep at night. I'm going to sit up on my pillows because I can't breathe. So they're going to be in your office if they got these problems, okay? I'm telling you these things I just told you. So you're going to see hepatojugular reflux. I've done that. I'll show you that when we do our lab. I'll put a table up here and I'll have my victim Bob here. And I'll show you how you look for hepatojugular reflux, pushing on the liver. You have to push that fluid right up into the neck because for a moment you see the jugular veins flash. And you can see that on a normal person. You don't have to have heart failure to shift that blood flow like that and to press firmly on the liver. And ascites is when there's fluid in the abdomen. You tap on it, and you can make it move around by having them lay on their side and then tap and then move back, and it'll shift position. Or sometimes they just have a big old belly. So they have severe right-sided failure, or the alcoholic maybe, and they have cirrhosis. I mean, the belly can just look like they're pregnant. Huge belly. They beg us to tap their bellies, but it never works. It comes right back. It's a really sad situation. The diuretics don't work. And they could have edema all the way up their legs. They could have tree trunk edema where their legs are so big from severe right-sided failure and severe tricuspid regurgitation where they're like firm the whole thing. They don't even pit anymore. They're just like tree trunks. And they get red. They get stasis dermatitis where they have scaly or red areas, or they get a cellulitis where it's just red because the blood just can't return well. They get inflammation. Obese people sometimes also have stasis dermatitis, because the flow is stopped by the fat. Pulsatile liver, you actually feel a pulse, put your hand over the liver and you feel a heartbeat in it. And hepatomegaly, you all learn how to check for that. And I check for it a little bit different than the way you guys were taught with the hooking. I like to do a different way. I'll show you my way. No way is the perfect way, but works good for you. Okay, so right-sided failure and severe tricuspid regurgitation is not hard to recognize. It is quite different from mitral regurgitation. Mitral regurgitation is usually tolerated for years and years. But tricuspid regurgitation, if it's just trace, then it's physiologic on the echo. But if it's severe tricuspid regurgitation, you start seeing things called right-sided failure. People like to still use that differentiation right and left. But I just gave an example of how a left-sided lesion causes a right-sided problem. Remember, that was that left-sided lesion I mentioned. Mitral stenosis could cause a problem all the way on the right side of the heart, just by changing the intracardiac pressure. Okay, so the treatment, you treat most heart failure with loop diuretics, they're called. Furosemide is a prime example. Least expensive, it has side effects. We'll mention it again under drug review. There's furosemide, there's bumetanide, called Bumex, torsemide, called Demodex. There's other ones, Edequin, things like that. And these are given intravenous, and you don't give these at home. You give oral diuretics at home, but they're not as effective as furosemide. Has side effects, can cause hearing loss and tinnitus. Tinnitus is ringing in the ears. So if you can't help them, then you could consider surgery. And the surgery, it's better to repair it than replace a tricuspid valve. So they sometimes try and do a suture annuloplasty. Or the ring, remember I told you about the Cosgrove ring, they can put that in the tricuspid position as well. So first you're treating with diuretics, and if that's not adequate to remove the right-sided elevated pressure, then of course ACE inhibitors, or ARBs, which we mentioned yesterday, are excellent for this condition because they reduce, remember, preload and afterload. So you give them the dose that they can tolerate without hypotension, because they're actually very good for lowering blood pressure. Remember the snake venom? I told you snake venom has the prill drug in it. That's what it was developed from, and it makes the animal vasodilate and lose consciousness so the snake can eat them. The snake just wants it to be unconscious so he can eat them. Actually eats them alive, but good for it to be unconscious. Okay, so there's a ring sewn in place. See the leaflets, how incompetent they are? And then they squish them together. Some symptoms, if you have endocarditis of your heart, are night sweats and chills, and they feel very, very ill. I've seen patients they lose weight, they don't have an appetite, they're nauseated, they're very ill. The bacteria in their bloodstream, it can go anywhere. You can get septic emboli coming off the infected valve to go to your brain, your kidneys, your joints, any organs you could have. You could have spread of the so it's a very, very serious and life-threatening infection. They have to be hospitalized to start treatment for it, to gain access and make a diagnosis. So you always order blood cultures before you give them antibiotics. And now there's the usual treatment is vancomycin. Now there's vancomycin-resistant antibiotics. So it's a huge problem. And we always consult the infectious disease specialist when we get something like endocarditis. When we get that in cardiology, so we see them and the IV specialists see them. So they take responsibility for choosing the correct antibiotic. And you would have the responsibility if someone came in with a FUO fever of unknown origin, or just this whole story of night sweats. You would hear, if you especially heard a new murmur, you're definitely going to get an echocardiogram. You might see the vegetation. The next test to order would be a transesophageal echo. Remember we talking about that? Putting the tube down the esophagus, get a really good picture of what the valve looks like. And so you would order the echocardiogram, and then you would probably order a cardiology consult, and you would order an infectious disease consult, and you would not start antibiotics. You would order the blood cultures, and you would let the IV doctors do that first dose. Or if it was protocol in your hospital to go ahead and order the antibiotic, you would just make sure you got the blood cultures done from at least 2 sites. because one might be contaminated with bacteria on the skin. So all this stuff, it would be a protocol. So you would know people that come in with a fever, suspected endocarditis. It'll be written out. A lot of the orders are already pre-printed, what you're supposed to do. So it won't be that scary, that particular thing. But they're really sick people. They need to be admitted to the hospital. They have new murmur, high fever, or endocarditis. You don't go home with that. So what if they didn't come back? You said, oh, come back tomorrow. We'll get your blood culture. Come back tomorrow. Well, they might have heart failure, or just what if they don't come back? And that would be malpractice. We do the right treatment to let them go home. Okay. So they can also, if they have endocarditis within a year of getting a new valve, it's usually the technique, because remember I told you to be indolent, and it could just be, bacteria could just sit in there and be encapsulated and just grow, and they might not get sick for a long time. So months and months later, they could have fever and have endocarditis from your technique. So surgical, the cleanliness is really important. You can get endocarditis if you have, let's say you had a diverticulitis. It could go from the gut, and you could have a ruptured diverticulum. It could get into the bloodstream. It could get in from the mouth. That's the more common cause. It could get in from people injecting it themselves when they have their IV drug abusers. It could get in from not an IV drug abuser, but just someone who had an IV and they got a phlebitis, and it just, because they were immunocompromised, it just took over and it infected their valve. So those are the ways you get it. IV drug abuse. Iatrogenic, y'all know that word? Iatrogenic?
We did it.
Yeah, iatrogenic means caused by the medical profession. Somebody caused it. Hospital infections are iatrogenic. Or from an infection, even in, sometimes people get it in the bone. It's usually an abscess tooth. So the IV doctors, they search for the cause of it. If it's coming from their teeth, they need dentures. They got to pull their teeth out because they're going to keep getting infections. And if you have a life-threatening endocarditis infection, and you have an abscess in your teeth, then your teeth probably need to come out. You're just a person that your teeth are rotting. When you get older, your teeth go bad. Okay. So what you have to do is, you can't put the artificial valve in until you sterilize the blood. So once the blood cultures are negative, then you can have surgery, because you can almost never get rid of the infection. It just stays in those vegetations. You've got to cut them out, and you can't just cut out the infection. The whole hardware is infected in a space, so they have to get a new heart valve. But they can't until you got the infection out of the body, and you've got to figure out where it came from. Because if you didn't figure out where it came from, you're gonna get it again, and they could die from it. So here's some people that need prophylaxis if they have an incompletely repaired or unrepaired cyanotic congenital heart disease, obviously, tetralogy or below. So it's a little controversial about holes in the heart. If they have an ASD, should you give them? Most people think you should, because it's not been repaired. If they have a small hole. So with palliative shunts and conduits, you want to go ahead and keep them on that, because supposedly they could grow some bacteria on the material that you put between their holes. So if you completely repair it during the first 6 months after the procedure, now that does not include pacemakers. Pacemakers do not require prophylaxis. Also, hip replacements don't, but some doctors, when they say, oh, you have an artificial hip, you need antibiotic prophylaxis, i.e. when you have your teeth cleaned or any kind of mucous membrane manipulation, such as a cystoscopy, or maybe a BPH surgery, a TURP, transurethral resection of the prostate, or something like that, where mucous membrane is manipulated. And because bacteria crosses really easily across mucous membrane, your bowel is a mucous membrane. So if you have your teeth cleaned, the bacteria from the little cuts in your mouth gets into your bloodstream. So also from the urogenital canal or tract, you also can get infections, of course, rectal, kind of colonoscopy, things like that. They give a dose of antibiotics for colonoscopy because bacteria can pass through that into the bloodstream. So not just teeth cleaning, but any kind of manipulation of orifices. And of course, a heart transplant. They're immunosuppressed to start with. So completely repair congenital heart defect is an indication. First 6 months after the procedure, and anything with a residual defect. And that's it, so only got half hour early, but better than nothing. Thanks for waking up.